Everybody can check on their left hand and they will have a scar. That scar is because of the BCG vaccination.
Tuberculosis still holds a stigma in the society. People still fear it.
Tuberculosis stigma is...
India has the highest TB burden. Are there any standout initiative or breakthrough happening right now?
India happens to be the mecca of TB.
There seems to have a surge after post-COVID to this tuberculosis infection. So what's in your opinion?
So COVID infection was interesting from the perspective of infectious disease.
So what in terms of funding, global health priorities and public awareness? Can TB ever be fully eradicated? Welcome back to another episode of Techfluence. As a part of our special series of MTech, we are thrilled to host leading voice of infectious disease research, Dr. Ashwini Kumar, Chief Scientist at CSIR MTech. Dr. Kumar, expertise in tuberculosis pathogenesis is not just timely, it's vital.
Good morning, doctor.
Welcome to our show.
Good morning.
Welcome to Techfluence.
Thanks for having me here.
We want to know what drew you to this challenge and what keeps you motivated.
So I must tell you one anecdote how actually I came to tuberculosis. So as part of, I did my MSc in biomedical science. As part of our dissertation, we have to do research for 6 months, and I chose Patel Chest as my dissertation project. Patel Chest Institute is a big institute focused on chest diseases, and there I joined lab of Professor Mridula Bose. She was a clinician. She was tending to patients of tuberculosis, and my job was really very simple. We will get 10 to 15 sputum samples. These are the samples that TB patient produce, and I have to culture them and look at their drug sensitivity and drug resistance profile, and everything was normal until I draw my attention to one of the samples. The bacteria isolated from this sample was resistant to all the drug, and when I looked at that, I went to Dr. Bose and I asked her how we are going to treat this person. She said we are not going to be able to treat her because she has already collapsed to TB. So that was a big thing for me, because at that time I was very young, 20 years old, and I was not really serious about what we are working on. And when you see somebody dying of TB, that was a big incidence for me, and that actually kind of drew me more towards tuberculosis. Then I chose to do my PhD thesis also in tuberculosis. So that is the reason I came in TB, and I learned more about it. Then I became more interested in it, and that is how I still work on TB, and it has been more than 25 years now.
Tuberculosis still holds a stigma in the society. People still fear it. So how should we actually look into it?
Yeah, tuberculosis stigma is there because if you look at older movies in around 1950s, 1970s, tuberculosis was like a death sentence. And if we look at the disease spread, this is much more infectious than we have seen recently SARS-CoV-2. It is much more infectious than that. In SARS-CoV-2, in COVID infection, an individual will end up infecting around 2.5 to 3.5 people. That is the R0 value that we call. But if left untreated, a TB patient end up infecting 10 to 20 people anywhere depending on the conditions. So it is far more infectious. So because of that, there is stigma, and in earlier times TB patients were put in a quarantine place where they were given food and so on, and so it is very highly infectious. And I will just give you one more anecdote about it. In older times, to figure out how infectious TB is, scientists did a wonderful experiment. So they housed some rabbits on the first floor of a hospital, where on the ground floor there were patients, and they just opened the windows of the 2 floors. All the rabbits on the first floor were infected with TB. So that is how much infectious it is, and because of which there is a lot of stigma in the society. But in 1970s we got our drug treatment. If we start drug treatment early, if we detect the TB infections early and put them on drugs, in around 14 days time after treatment, the patient stops kind of shedding this infectious bacteria. So if we can catch patients early and put them on treatment, we can really cure them.
So yes, I also remember it was in my childhood days when I had observed somebody had TB where we used to stay. So he was kept in they built a room upstairs and they kept him there. And I still remember they used to give his food on the stairs, like they used to leave it there on the stairs, and used to take it from there. So that's how tuberculosis is in our
in our mind.
Our mind, in the back of our mind, it's still in the same way. So
see this stigma originates from one very important thing. There is a reason for this stigma. The reason is that the TB is caused by a pathogen called as Mycobacterium tuberculosis, and this is the biggest killer of humanity as an infectious agent. There is no other pathogen which has killed as many human individuals. And if you look at our time of industrialization in Europe, in COVID we have seen that people will get infected from COVID, and then out of 100 people, maybe around 1% people will have to go to hospital, and out of them around 2 to 5% people may die of COVID. In TB, in older times, in 1700s to 1900s, in Europe, we have seen waves after waves of TB, where 1 in 4 people died of TB. So TB has killed a lot of humans, and because of that killing, there is stigma. So in Europe, because TB was so rampant, so a lot of literature is there. So when you have an adversary which is unconquerable, you kind of romanticize it. So there is a lot of historical literature. When people got contracted with TB, it was like a death sentence. So a lot of poems and romantic literature has been written. So when people cough, their cheeks become red, especially in Caucasian people. So it was put in a state when that this is a death sentence and God has called this person, and now it has red cheeks, has become very thin and frail. So at that time, we were not able to really conquer this adversary. So we even made it like romanticize this. So that is normal human nature. And in our part of world, because TB has been there for a very long period of time, we, instead of romanticizing it, we have created a stigma around it. The stigma was maybe valid until 1970s, but the stigma should go away now. We should just take care of the patients who are infected with TB properly, and then their infectious stage will go away in 14 to 20 days, and then they will not really spread the TB. So the stigma should be taken out of our society, and we should be more proactive to treat TB patients.
Good to know. So, Doctor, India has the highest TB burden globally. So, what makes our research approach unique? Are there any standout initiative or breakthrough happening right now?
Yeah, unfortunately, India happens to be the mecca of TB. Unfortunately, of all the cases reported in the world, 1/4 are in our country. Of all the deaths due to TB reported in the world, 1/4 are in our country. So it really is our problem, and we have to solve it. We are learning fast. We are making efforts to take care of the problem. There are very, very simple things that can actually eliminate TB. Government of India is working actively on this. So if you have looked at a TB patient, the image that comes to your mind is somebody coughing. Yeah. Somebody who was healthy has become very thin, and that is how the TB is. So Mycobacterium tuberculosis infects an individual, then take over the metabolism, burn a lot of energy and fat in that individual, so the individual becomes thin, very frail, the immunity goes down a bit. And very simple things like government has initiated, you give proper nutritious food to the patient. That helps a lot. So even these simple things, government has made it mandatory that all the TB patients who are housed in different wards, they should be given nutritious food. Simple things like giving them vitamin D, giving them iron helps. So these things are happening. But there are 3 fronts of TB that we need to focus on. The first is, how do we diagnose it? Our diagnosis is still based on culture. Culturing is the gold standard, and you need to have a culture to really do the drug sensitivity assays so that you can figure out which drugs will act best. And culturing takes a lot of time. So if I give a sputum sample today for 3 consecutive days, to get culture positivity, it may take me at least 14 days in the liquid culture. If I have to go for a solid culture, it will take me a month. So that is a problem. So diagnosis is still a problem. There are new interventions happening in the arena of diagnosis, but I think more is required. The second major thing with which you control disease, infectious disease, is you need to have a vaccine. We use a vaccine which is still very old. This was developed in 1930s. And then the third intervention is treatment. So treatment has its own issue. Because we are working on treatment, we can talk more elaborately about it. So in treatment, you need to take 4 drugs for 2 months. These are the frontline TB drugs. And then you need to take 2 drugs for 4 months. That's a big treatment. And we call it short course therapy. Directly observed therapy, short course. And this was devised in 1993 by WHO. Before this, treatment ranged anywhere, depending on the physician, from 9 months to 2 years. So that is why it was called short course. In comparison to a normal bacterial infection, where you will have to be treated by one single antibiotic for 3 to 7 days only. Here we have to treat an individual with 4 antibiotics and for 6 months at least. So that is an enigma. And my lab also tried to work on figuring out, why do you need such a long treatment? What are the reasons for it? How can we shorten the treatment? Can we devise strategies so that this treatment is short? So one of the things that I believe, all these drugs are okay, good drugs, although with the FDA regulations that are there, I'm not sure if any one of these will be approved today, because many of them have toxicity. So isoniazid and rifampicin have quite a lot of hepatotoxicity. So the individuals taking them may end up in clinic because of taking them. But these are the only avenues that we have. And without the antibiotics, I'm pretty sure even today TB is like a death sentence. So it is better to take these drugs. And these drugs are take care of TB good. So we have around 10 million to 11 million cases each year, and we are able to cure 90% of them. We lose around 10% of those individuals with these strategies. But still that 10% number is a million. It's a huge number.
Huge number.
So we need to do more in this direction. We need to understand. So my lab believes, so if I take these drugs and take them in the lab and put them on MTB culture in vitro in the lab, they work beautifully. They can kill mycobacteria to huge extent. Within 2 weeks, they will just eliminate a lot of pathogen. But when I do a mice infection or a guinea pig infection and give these same drugs, they don't really work that efficiently. So my lab works on figuring out what changes in mycobacteria during infection. So mode of life is very simple in the lab. Bacteria wants to eat, grow. And when these drugs come in, they kill them fast. But when the bacteria goes in a host, it does not really grow as fast. It uses different strategies. Those different strategies are, if you look from the bacterial perspective, they're really beautiful. I'll just give you another anecdote. If I get infection today, unlike diarrhea or dysentery or cholera, within a week I'll show you the symptoms. But if I get infected with TB today, I will become diseased only after a couple of years. I will display the symptom of TB only after a couple of years. So TB takes that long to establish infection. And an important aspect of this disease is also that only 5% of all infected individuals will show disease, active disease. Rest 95% of individuals, they will be infected, but they will not be diseased. They are infected for their lifetimes, and they can develop this disease when their immune system goes away. For example, when they grow older, 10% of these individuals who have infection will become diseased. Unfortunately, that number of latently infected individuals is huge. A mathematical model suggests that anywhere from 1/4 of the world population to 1/3 of the world population is infected with TB. And more so in our country, where TB is endemic. What do I mean by that? There are tests through which we can figure out if a person has been exposed to TB or not. And we can see if the immune system is still recognizing the pathogen or not. And if you do that test in a population of 100 people, anywhere from 60 to 80% people will become positive, which means again 1/3 to 1/4 of the world population and 2/3 of our population is infected with TB. That's a huge number.
We have vaccine for it, so it was invented long back, and we had been using the vaccine throughout, right?
Yeah, yeah. So
everybody is been induced with the vaccine.
Yeah, you rightly said so. This BCG vaccine that we have was developed in early 90s. And was developed by one of the big pioneers in the field, Robert Koch, and people associated with him. And this is called as BCG, Bacilli calmette-guerin. Calmette-guerin were the people who actually developed this. And they actually, in those times, what happened is, you may have seen with the smallpox. So cowpox was a cousin of smallpox. You culture it for a long period of time, then the strain become attenuated and it is used as a vaccine. Same thing in those times they did with TB. So the cousin of Mycobacterium tuberculosis, which caused disease in human, was Mycobacterium bovis, which caused disease in bovine, in cows and buffaloes. And they cultured it for many years, and then they arrive at a strain which was unable to cause as severe infection in mice and other models, and this was termed as the vaccine. This is the vaccine that has been administered to the highest number of human beings. In our population, BCG vaccination is must. Everybody can check on their left hand and they will have a scar. That scar is because of the BCG vaccination. So it is one of the most administered vaccine, but it's not really effective because all of us are vaccinated with TB. Despite that, we have the highest burden of TB. So the vaccine works, prevent disease in children, but when they grow up in adults, it does not offer that much of protection. So those individuals who have been vaccinated, they can become diseased, unlike many other vaccines which work for lifetime and we don't get infected after getting the vaccine. So vaccine is something that need to be further developed. There is a lot of work going on this, but This vaccine is not good, but this is the only vaccine that we have as of today. There are some clinical trials going on. But trust me, there is a lot of work going on development of new vaccine, and it's really difficult to figure out something which works better than this vaccine. And there are some trials going on. Hopefully, we'll have something in few years.
There seems to have a surge after post-COVID to this tuberculosis infection. That's globally what it's been reading about. So what's in your opinion?
So COVID infection was interesting from the perspective of infectious disease. For last 2 decades before advent of COVID, we have seen through efforts of Government of India and RNTPC and WHO guided programs, we have seen a constant decline in TB incidence rate. And that was a good achievement, big achievement, because TB is still one of the biggest killers, and decreasing incidence was a good positive thing, and it happened for consecutive 2 decades, which was very, very encouraging. Unfortunately, what happened during COVID was that there was fear amongst patients to go to clinic because COVID was there and they did not want to really get infected with COVID. And because of COVID also, our health system was kind of taking care of COVID, and we were not paying as much attention to TB. So TB reporting, because less people who were positive with TB, they did not go to clinic, so TB reporting came down. And when COVID was taken care of, kind of, then people started to go back to clinic. And if we compare from 2020, 2021, in 22 and 23, we have seen a surge of TB again. But that is because people have started to go back to the clinics. And there is more detection, and if you compare from previous year, there is definitely a surge. But I'm pretty sure with the efforts that are going on, the programs that are there, we will come back on the path of seeing the declining trend of TB soon.
So what in terms of funding, global health priorities and public awareness? Are people more informed now, or has TB slipped back into the shadows?
I believe rightly so, because our life expectancy has increased over last few decades. We are focusing more on, in terms of research, on diseases, other diseases like atherosclerosis, geriatric problems, and so on, Parkinson's disease, and so on. However, infectious disease, in my view, because I work on infectious disease, are still very relevant, very important. And we still have to work on infectious disease because, see, our population is now increasing, especially so in metropolitan cities. The population density is quite a lot.
Yeah.
And if you look from the perspective of pathogen, we are like food for them. Where there is more food, there will be more of those pathogens. And with urbanization and ease of travel by flights and so on, an infection anywhere can spread rapidly, and we have seen that with COVID. It started in Wuhan and rapidly, in no time, spread to the whole world, and the whole world actually saw such a fast spreading pandemic. So with urbanization and ease of travel, when we are connected with each other so quickly, infectious disease takes again a special place. And I believe we need to prepare for such pandemics, because the urbanization will not stop. This is the requirement of development. So urbanization will happen more. We will have smaller cities growing into bigger cities. For example, Chandigarh has grown quite a lot in last few years. So this will happen, and this should happen. This is not the wrong thing. But with the urbanization, the infectious disease will become more prevalent. Pandemics like this may happen more. Mathematical models also suggest that with urbanization, these pandemics can happen more. We have to prepare for those pandemics. Right now, ICMR, DBT and DST and CSIR, all of them are having drawing policies, making networks of these infectious labs, so that if pandemic happen again, we can quickly work on it. The white paper document for handling such a pandemic again, that they are being prepared. So infectious diseases are gonna be there. And we have seen from in past that whenever pandemics happens due to viruses, there are large number of deaths. But whenever they are happening due to bacterial infections, there are even larger number of deaths. Viruses spread rapidly, and they have their own lethality. Some viruses like Ebola can be very, very lethal. But in past, we have seen the bacterial pandemics, when they happen and they are much more lethal. So we have to prepare for both viral pandemics, bacterial pandemic, and other infectious disease also. And I believe that government is already doing so. They are going to spend more money on infectious disease, and I believe rightly so, there is need to spend more money in research on infectious disease. We need to prepare ourselves, because with urbanization this is going to happen. I don't think there is two opinion about it. So we have to prepare for this, and we have to keep our research infrastructure strong, so that even before the pandemic happen, we know how to stop them. And if you stop the pandemic right at the time of beginning, we can save millions and millions of lives. So it is important to be prepared and to act timely.
That's a good to know.
Yeah.
Another thing, if I can add, we already have things like measures for taking care of infectious disease, but I believe if we can have something like Center for Disease Control in US, kind of national agency which acts the moment a pandemic or something is happening, and comes up with guidelines and take care of the infection right at the beginning, that could really help. Preparedness is the key. Coming back to TB, because we have been in TB epidemic for very long period of time, I believe we need to spend a little bit more money to discover new drugs, because these drugs that we have currently, the bacteria is becoming resistant to them, and the new approved drugs such as bedaquiline, predominant and delaminid, they're reserved for treating MDR patients and XDR patients. So we need to bring in new regimens of drugs, so that if there is a TB pandemic again, and our efficacy of treating people decreases because of drug resistance, we have something in our arsenal to take care of this.
You were awarded with the most prestigious science award, that is Santi Swarup Bhatnagar Award. So it's a pride to you, it's pride to the CSIR MTech, it's pride to us. So can you say something about it?
So as I told you, TB treatment takes longer, and my lab works on figuring out why does it take so long, and why the pathogen, when it is in infected host, why does the drugs don't work as effectively. So we have proposed a new hypothesis to explain this, and that is that Mycobacterium tuberculosis, they make these biofilms. So biofilms, if you look from the perspective of a common person, so this is like making a castle for yourself. When you're going in a host, you make this castle. So in this castle, because this is your castle, the host immune system, the cells of immune system, they cannot come in. The macrophages, they are big, and so in this castle they cannot enter, and they cannot catch the pathogen. They cannot kill the pathogen. The other advantage that these castles offer to the bacilli is that the drugs, they become less efficient to work and kill mycobacteria in these castles. So this actually award I have got is because of my wonderful students who have worked all these years. And our lab collectively with my students, we made a beautiful discovery that mycobacteria make these castles. And to make these castles, they use something very unique, which is called cellulose. So these clothes that I am wearing, these are made up of cellulose. So mycobacteria utilize the same material to make these castles. So when you make castles, you make modern building, you need pillars. So mycobacteria use these cellulose as the pillars. And in this, they put a lot of other polysaccharides. So once this castle is there, these houses are there, they're living safely. My students made this beautiful discovery that you can destroy this castle by using an enzyme called as cellulase. So when you destroy these castles, the efficacy of drugs that we have, that increases. So we have done experiments in vitro where you show that the drugs don't work effectively in the biofilms. And when you use cellulase, they kind of destroy these biofilms, and the drugs are able to kill. So then my other students, new batch of students, they said that let us look for presence of these biofilms in infected host. It was challenging because it has never been done. And we utilized this cellulose as the biomarker for detecting these biofilms. So we detected these biofilms in experimentally infected mice. We detected them in experimentally infected non-human primates and in clinical samples. So we have been studying mycobacterium and this tuberculosis scientifically for last 150 years. But we did not know that TB is a biofilm infection. So my work really brought out that TB is in fact a biofilm infection. And if we can destroy these biofilms, we can kill mycobacteria more rapidly. Maybe we can have a shorter treatment. The other thing that came out of this work was that if we have a pathogen which does not make these biofilm, then they really don't infect mice as effectively, suggesting that it is one of the key virulence factors of mycobacteria. So for mycobacteria to cause infection, that is what my lab has shown, and that now it is reproduced by many other labs. This capability to make these biofilm is very important. If bacteria is unable to make these biofilm, they are unable to cause infection. So in my view, if we understand how does mycobacteria make these biofilm, and we can bring out new interventions to disrupt these biofilms, we can perhaps shorten the treatment of tuberculosis, and that can solve a major problem. So for that discovery, for beautiful work of my students, I was awarded with this Shanti Swarup Bhatnagar Prize, and now we are working on methods through which we can disrupt these biofilms. My lab also works on figuring out new regimen, because this current regimen is now more than 50 years old now, and we need to come up with a new regimen. So I, along with some colleagues from MTech, we work on developing those regimens also.
Right.
That's a pride for MTech, I must say. So, doctor, can TB ever be fully eradicated? Because WHO says yes by 2030. India is even more ambitious, aiming for 2025. So, how realistic are these goals?
Yeah, so eradication of TB is important. We need it. WHO has also put a deadline, and we also have come up with a deadline. It's important, it's ambitious, but we need to do ambitious things the way we are growing, our country is growing. So we should definitely have that. Unfortunately, the problem with TB, as I told you earlier, is that a lot of people are latently infected with TB. They are not deceased, but they still have TB. So if their immune system goes down, let us say somebody got arthritis and they take immunosuppressant for taking care of arthritis. In our country, they develop TB. So somebody is having HIV. So because they were already latently infected with TB, they develop TB. So that's a problem. So that is the kind of riddle in eradication of TB. I'll just tell you one interesting thing. In Europe and in US and in the Western world, TB did not really got eradicated because of drugs. It got eradicated because of improved health and hygiene condition. India is quickly and fast moving towards that. I believe with the interventions that are in place, with the government work that is coming in place, improved health and hygiene status of our country with better economics and all will also expedite that process. But for me, as a researcher, it is difficult to put a date to it.
But we will hope for it.
But I'm pretty sure this will happen.
So with that hope and faith, we conclude here, Doctor. Thank you so much for giving us your time.
Thank you so much for giving me the opportunity and inviting me for the podcast. It was really good to interact with you all.
Thank you.
Thank you so much.